Hi, my name is Tamara Rodriguez Rugel, and I'm going to talk about immunotherapy for unresectable stage 3 non-small cell lung cancer. About the definition, non-small cell lung cancer is the most common type of lung cancer. Squamous cell carcinoma, adenocarcinoma, and large cell carcinoma are all subtypes of non-small cell lung cancer. Smoking causes the majority of cases, around 90%. The risk depends on the number of cigarettes you smoke each day and how long you have smoked. Being around the smoke coming from others, passive or indirect smoking, also increases the risk of suffering from this disease. However, some people who have never smoked develop lung cancer. Constant exposure to high levels of air pollution and drinking water containing high levels of arsenic can increase the risk of lung cancer. A history of radiation therapy to the lungs can also increase the risk.
So what defines stage 3 unresectable non-small cell lung cancer? Well, first, it's important to distinguish patients who have potentially resectable stage 3 disease versus those who have unresectable stage 3 disease. In general, stage 3 disease is defined by disease that involves the mediastinum. The mediastinum is this compartment in the midsection of your chest that lies between the two lungs, the heart, lymph nodes, the esophagus, the trachea, various blood vessels reside in that region. And when disease involves the mediastinum, that section between the two lungs, oftentimes it is difficult for a surgeon to surgically resect it and get all the disease out that they can see. And so the vast majority of people who have disease involving the mediastinum will be considered to have unresectable disease. There are some exceptions to this. There are some patients who we think may have stage 1 or stage 2 disease that does not involve the mediastinum. The surgeon will routinely do surgery and remove lymph nodes in that portion of the chest and will incidentally find that there is cancer in the lymph nodes. In that case, those patients also have stage 3 disease, but they were able to undergo a surgical resection. There are also a small subset of patients who have clinically known disease in the mediastinum that's low volume, that may require a lesser surgical resection. For occasionally, patients will be able to undergo surgery in that group. However, the vast majority of people are going to have pretty advanced disease in the midsection. They're going to have multiple lymph nodes that are enlarged. They're going to have tumors that involve major structures. They're going to require large operative procedures. And for those patients, we consider them to be unresectable. I would estimate that probably 3/4, maybe 80% of people who are diagnosed with stage 3 disease would be considered unresectable. And some patients may be technically resectable, but they may be medically inoperable. In other words, removing the lung or doing that sort of operative intervention might be too difficult for them. They may not have the heart reserve or the lung reserve to be able to survive a procedure like that. So that group of patients oftentimes is also not treated with surgery.
Applications in medicine. Stage 3 non-small cell lung cancer includes either locally advanced primary tumors with infiltration of vital mediastinal organs or involvement of locoregional mediastinal lymph nodes. Over the past decade, chemoradiotherapy has remained the standard of care for stage 3 non-small cell lung cancer. Eligible patients had disease that had not yet progressed after they had received at least 2 cycles of platinum-based chemotherapy concurrent with radiotherapy, chemoradiotherapy, at a dose of 54 to 66 GY. A total of 713 patients were randomly assigned in a 2:1 ratio to receive an anti-program death ligand 1, anti-PD-L1, antibody durvalumab at a dose of 10 mg per kilogram of body weight or placebo every 2 weeks for up to 12 months. Overall, survival continues to be the standard for outcomes in the treatment of locally advanced non-small cell lung cancer. Nevertheless, in a Pacific study, progression-free survival was almost 17 months in the durvalumab group, which was almost 1 year longer than progression-free survival in the placebo group. This duration is unprecedented in stage 3 non-small cell lung cancer. Additional relevant surrogate endpoints include the development of new distant lesions that were more frequently observed in the placebo group than in the durvalumab group. Most notably, brain metastases developed in twice as many patients in the placebo group as in the durvalumab group. 11.0 percentage versus 5.5 percentage.
Durvalumab after chemoradiotherapy in stage 3 non-small cell lung cancer. This study was published in the New England Journal of Medicine in September 2017. This phase 3 study compared the anti-PD-L1 antibody, durvalumab, as consolidation therapy with placebo in patients with stage 3 non-small cell lung cancer. These were all patients who did not have disease progression after 2 or more cycles of platinum-based chemoradiotherapy. These patients were randomly assigned to receive durvalumab at a dose of 10 mg per kilogram of body weight intravenously, or placebo every 2 weeks for up to 12 months. The study drug, durvalumab versus placebo, was administered 1 to 42 days after the patients had received chemoradiotherapy. The median progression-free survival from randomization was 16.8 months with durvalumab versus 5.6 months with placebo. The 12-month progression-free survival rate was 55.9% with the durvalumab versus 35.3% in those treated with placebo. The 18-month progression-free survival rate was 44.2% for those treated with durvalumab versus 27.0% for those treated with placebo. The response rate was higher with durvalumab measured at 28.4% versus placebo at 16.0%. About 72.8% of those treated with durvalumab had an ongoing response at 18 months versus 46.8% of the patients treated with placebo. The median time to death or distant metastasis was longer with durvalumab measured at 23.2 months versus placebo measured at 14.6 months. The authors concluded that treatment with durvalumab after chemoradiotherapy was associated with significantly longer progression-free survival compared with placebo. Thank you for watching.
Issue applied in Ecuador. Worldwide, approximately 5,000 patients receive a diagnosis of unresectable stage 3 non-small cell lung cancer every year. This number constitutes approximately 1/3 of all patients with non-small cell lung cancer. In Ecuador, this type of tumor is one of the most deaths per year, according to the National Registry of Tumors of SOLCA, and is located in the 3rd place after the stomach and the prostate. Immunotherapy is also being applied in Ecuador against lung cancer, which reduces the risk of patient death by 51%. The therapy, consisting of the combination of the drug Keytruda with chemotherapy, showed to reduce more than half the chance of death compared with the treatment that only uses chemotherapy for patients with non-squamous metastases and non-small cells.
We took patients with stage 3 non-small cell lung cancer that was not amenable to surgery. And those patients were treated with what we would have considered the standard of care, which would be concurrent chemotherapy and radiation. And then the trial placed those patients, all the patients in this case, on a drug called pembrolizumab, which is a PD-L1 inhibitor or a checkpoint inhibitor, a form of immunotherapy. And those patients received that therapy for up to 1 year. And what we were looking for was whether we could improve the time to the development of distant cancer or death in those patients. And we also looked at the development of local cancer and also overall survival. And the study looked at all those endpoints as well as the toxicity of adding that medication after concurrent chemoradiation. And when we compare the addition of this immunotherapy medicine to what was the previous standard, which is just chemo and radiation followed by observation alone. When we add this medicine, it looks like it significantly delays the time to patients developing distant cancer, delays the time to patients developing a recurrence of their cancer, and we hope that eventually we're going to see an improvement in the survival of our patients and hopefully an increase in the cure rate of patients after concurrent chemo and radiation. So thankfully, patients are doing well enough on the study that we haven't gotten to the point yet where we can really say whether it improves their survival or not, though based on how well they're doing, we're hopeful that that will be the case. Our study was similar to another study which has come out in the last year, showed very similar findings. We think our study confirms their findings. The addition of these medications and the improvements that we're seeing are very exciting, both for us as physicians, but also, very exciting for our patients. And we think the next steps, number one, is trying to figure out why the patients who didn't benefit. Is there a test that we can do prior to giving these medicines that will tell whether or not they will actually respond to them or whether or not their cancer will come back? Is there something about their cancer or the way their chemo and radiation was given that can help us understand why their cancer returned and someone else's did not? And then to build on the future and newer therapies, we have to see whether, adding things on to this immune therapy regimen, may help improve outcomes even further. The standard of care for stage 3 lung cancer is really changing. And if you or someone you love has recently been diagnosed with stage 3 lung cancer and been treated with chemotherapy and radiation, I think you should have a discussion with your oncologist about whether or not immune therapy may be the right choice for you.
Pros and cons. About pros, immunotherapy will prolong the life of patients with lung cancer that cannot be resected. Another pro, this type of innovative treatment allows us to have more alternatives for the management of a disease as aggressive and high incidence as cancer management. About the cons, being an innovative treatment presents a high cost to access it, and not all cancer patients have the necessary resources to pay for it.
Certainly now that the FDA has approved durvalumab as consolidation therapy for stage 3 disease after concurrent chemotherapy and radiation, we now finally have consolidation therapy that really does make a difference for our patients with non-small cell lung cancer after concurrent chemotherapy and radiation. This was based on the PACIFIC data that was recently presented, showing a significant control of disease and progression-free survival advantage to receiving durvalumab over placebo after having stable or responding disease to the standard chemotherapy and radiation. I think very importantly, they did not see a significant increase in toxicity. Specifically, we're always concerned about pneumonitis in this setting, but it did not seem that durvalumab added to that toxicity. Certainly we want to see the overall survival data, and hopefully that will be coming as well, but now we have a standard of care. If you have a patient with unresectable stage 3 disease and you plan to give concurrent chemotherapy and radiation, starting durvalumab after the concurrent therapy is completed, does improve progression-free survival.
In conclusion, immunotherapy offers a great opportunity to prolong the life expectancy of patients with non-resectable non-small cell lung cancer. This type of studies brings us a little close to discovering a definite cure in an illness of such high incidence as this one.
The standard of care treatment for stage 3 unresectable non-small cell lung cancer really had not changed for almost 20 years. It had been long established that chemotherapy does add to radiation therapy for patients. It had also been established that concurrent chemoradiation was better than sequential chemoradiation. Unfortunately, we'd sort of hit a plateau, hadn't improved things beyond that. Studies looking at induction chemotherapy were not successful at improving survival. Studies of consolidation chemotherapy were also not successful at improving overall survival. And looking at a variety of targeted agents and anti-angiogenics also did not move the ball. Having said that, the Pacific trial did move the ball, and we do have a new standard of care. So in that study, patients who had unresectable inoperable stage 3 non-small cell lung cancer were all given chemo and radiation. About 20% of them actually got some induction chemo. None of them got consolidation chemo, and they all got concurrent chemoradiation. It was all platinum-based chemotherapy with a second drug, and the second drug could have been a whole variety of different drugs. And the radiation dose was not mandated either. Most patients got 50 to 60 gray of radiation. And patients actually did not even enter the trial until after they had finished chemoradiation and achieved non-progression, so they hadn't developed metastatic disease. This was a global trial, it was over 700 patients, and at that point of completing chemoradiation, they were randomized in a 2-to-1 fashion to receive either adjuvant durvalumab every 2 weeks for a year or adjuvant placebo given IV every 2 weeks for a year. And what the study results show is that patients had better time to metastatic disease or death, better progression-free survival, and actually better overall survival, both clinically and statistically significant. And that really does establish a new standard of care.
Thanks.